Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
This is Dennis, and today I'm with Tom. How are you doing today?
Hi, I'm good. Good.
For coming on to the podcast. So, a previous podcast, we talked to Victor about what his experience was in Burma, and you were on the receiving end of all his patient care. And so I wanted to talk to you about your end of the deal.
Yeah, well, that's great. I'm very happy to be here and talk about that.
So if you would you mind just doing just a real quick introduction of yourself?
Yeah, sure. So my name is Tom Avery. I am 36 years old, and I am a German citizen, but my roots lie in the United States, South Korea. I'm married to my wife, Hannah, who's Dutch. We have two kids who are 8 years old and 2 years old, and I'm currently working at the Department of General and Abdominal Surgery at the University Medical Center in Freiburg in the southwest of Germany. And I am what you would probably call a senior resident in the United States. So I'm still in training to become a surgeon. Yeah.
So how did you get mixed up with Victor?
Yeah, so that's a bit of a story. So right after graduating from med school, I always wanted to go on humanitarian missions and do something meaningful with people who are affected by crisis or are displaced, are confronted with a war-torn situation. But it was very difficult to find a way into that world. There are many big humanitarian organizations that, of course, offer this type of work, but they also demand quite a lot of conditions, or they demand a lot of experience, and there are very specific conditions that you have to meet before you're considered for this type of work. And I was, of course, also aware that if you go on humanitarian missions, especially as a surgeon, and you go with limited experience, limited exposure, that very quickly you can end up in very challenging, maybe even traumatizing situations. And so I was also aware that, of course, I would have to be further along the training program and develop more skills and just gain more experience before going on a humanitarian mission into a war-torn area like Myanmar. And in the end, it was actually my wife who came across the documentary of the Free Burma Rangers, the humanitarian organization that works in Myanmar already for about 30 years. And we were first amazed and overwhelmed by what we saw. And at some point, I just contacted Free Burma Rangers and asked them if I and my family could support them in any way. And so that is how we, got talking, and how in the end we planned to go on a mission together. So when I went into Myanmar together with Free Burma Rangers, I didn't exactly know what kind of medical team I would be working with and who exactly would be on that team. And then when we first met everybody who was actually going on the mission, that's when I met Vic, who had stayed at a different location of Myanmar before going on that particular mission into the eastern province or state of Myanmar called Karenni State.
A young physician full of hopes and dreams, and we go to a place like Myanmar to obviously help as best we possibly can. What, I guess, your expectations and what was the reality you're able to provide?
Was really like critical care. What I've seen in the country was very shocking. I was expecting, some hospitals to still be intact and some base level of healthcare to be functioning, but this was all not the case. And I was shocked to see that basically every hospital, every healthcare facility that we drove past was already bombed or had been burned down. And it was just devastating to see how little care also the civilians received. I was also very surprised to find that the resistance fighters, they often did not have very skilled medical teams or even surgeons on their teams. I mean, sometimes they did, sometimes they didn't, but they had to work with whatever they had and what kind of medical personnel they could gather. And so, in retrospect, I think the most important work we were able to do as a whole, like me and the medical team, is to kind of bridge the gap between the front line and then the first higher echelon of care. Because often we were confronted with a situation where evacuating any patients from the front line to the next sort of functioning hospital would take about 6 to 8 hours, driving on these pickup trucks over bumpy roads. I mean, far from ideal when thinking about, medical evacuation. We didn't have any air support. Evacuation by air was not an option. Sometimes when we're very close to the Thai border, we would be able to evacuate the patients to Thailand, and then it would be specific Thai hospitals along the border that would then take all these patients and give them the care that they needed, which was a huge blessing. But still, when we were at the front lines, we were confronted with the situation that anyone who we would decide to evacuate would have to be transported, for at least a couple of hours. We were very well aware that before evacuating, this patient would need proper stabilization and, would have to be stable enough to survive this long journey. And if I think back, we were able to provide this care, this stabilization of patients in almost all cases that we dealt with. And so I think this was the most important and most significant work that we did. Stabilizing these patients, performing certain damage control, surgeries or interventions, to stabilize them and then shipping them off to the next echelon of care.
Think of damage control surgery or, having a surgeon on the battlefield, they're thinking about, cross-clamping the aorta so that they can stop a bad abdominal bleed or, these, massive surgeries when, that you might not have resources for something like that. What he actually needs is a chest tube. What he actually needs is, maybe a unit of blood, just so that he can be stable enough to then go ahead and push them farther back so they can get to, a higher level of care, or somebody that has more resources available to do a more definitive job.
Yeah, I totally agree on that. Also, before I went on this mission, I was having these thoughts of, oh, well, what should I do when I'm confronted with a situation like what you were describing, and being confronted with a decision regarding possible thoracotomy or laparotomy in the field. And I was also worried because I was very well aware that we would have very limited resources. We didn't have an anesthesiologist, we didn't have a ventilation machine, all those kind of things. We wouldn't have been able to intubate a patient in the field and then ventilate that patient and then do big surgery. That was absolutely out of the question. But then again, when we were at the field, we were actually not a single time confronted with this issue because no matter how close we were to the front line, I mean, the closest that I was to the front line was maybe 1 kilometer away from the front line, but still it would take the medics about 30 minutes at least to get a victim or a patient from the front line to this forward surgical unit that we established. Patients with severe injuries, injuries to the cardiac box or penetrating abdominal wounds going right through the middle, probably tearing open big blood vessels. I mean, they would not survive this transport.
Yeah.
You would have to have the capacity to start working on them with like massive resuscitation. I mean, right from the start. I mean, most of these patients, they didn't even make it out of the front lines. And I do remember from some stories or from, observations that Vic made out in the front line, that in some cases, some patients with really devastating injuries, they would survive the initial minutes, but then while being transported, they passed away. Because there was just no possibility of, that mass transfusion in the field or anything like that. And so we call this nature's triage. In the end, the patients that actually made it to our forward surgical unit had injury patterns or injuries that we were able to deal with properly.
Of time.
Yeah.
It's kind of a morbid way, but it does help you make those decisions when they don't make it for you to have to make that decision,
Yes, unfortunately, yes.
That doesn't mean you have a shortage of patients. So, some of the stories that Vic was saying is, arriving at your aid station with, 50 casualties, 20, 30 casualties, which is immediately a mass casualty, especially when you're dealing with, you're the one surgeon and you have maybe one or two helpers with you. I promise that's a mass casualty.
Yes.
For triaging, obviously they're probably not coming in one at a time, so they're probably coming in a handful at a time. How are you triaging? How are you allocating resources? How are you making those decisions about who is the guy that I'm going to tackle first?
So what we did, there are certain ways of setting up a forward surgical unit for, basically in treatment bay, even out in the field when you don't have any buildings. And so what we would do before this big event, we would carefully pick a location that would, suit our needs, and we would designate specific areas, for either the entrance area, and then would designate the triage area, and then like a pre-op area where we could already perform some resuscitation. Then we would have like a surgical unit, you could call it, or a place with a table where you could perform some surgery, and then there would be designated areas for the walking and talking and other patients with, let's say, less severe injuries that would not require surgical interventions. And then we would, go over the whole patient flow system, the whole triage process with the medical team beforehand, and even sort of, simulate a mass casualty event in that sense, to just, have everybody on the same page. Because what I noticed is that in every situation, every battle, every, mass casualty event, you were dealing with a very different medical team. We were not always the same people working together. Sometimes I would have this very, very skilled ER nurse from the United States with me on the medical team, who was like an absolute star regarding, triaging and coordinating and the oversight of where's which patient and how we're gonna organize everything in detail. But then during a different battle or a different situation, she would not be there. So there was like this huge gap to be filled. And then I was surrounded by a few medics, local ethnics who would hardly speak any English, and who had never gone through a mass casualty event themselves, who might have heard about triaging the first time on that day, So it was very, very different. Every time, we were confronted with mass casualty events. I think in the end, the best thing that worked very well for us was to go over this triage system together, and then also, I was the most experienced medical person on the ground at the time, to really try to always have an eye on the triage day to kind of see and understand, or also, ask the medics to just get me and discuss a patient when they were in serious doubt, and if they were dealing with an unstable patient. You just kind of discuss that with me, and so that I would also have some sort of overview of the most critical patients, and then decided together which patient would need immediate surgical attention or not. But I can tell you that was a very, very challenging thing to do, especially when it gets busy and you're confronted with multiple patients at a time, and then trying to keep overview in that kind of a situation is very challenging. But it did work out in the end.
Yeah,
I'm really glad that we didn't have situations where we missed big injuries, or we missed an unstable patient and that patient died in front of our eyes. I mean, that didn't happen. Somehow our system worked, but it was just very, very difficult because every situation was so fluid, and you would not have the same team performing having their roles. So it was also very difficult to, I guess in the ideal world, in an ideal situation, you would have this fixed team, with fixed roles. You could train, you could practice, and then of course at some point you know how everybody works and how you can communicate well, and then it's just like one machine that just well-oiled machine that works and works and works. That would be the ideal situation, I guess. But in these kind of crisis era situations and crisis areas, I think that's a very difficult thing to achieve or to have.
I'm sure, especially when you're talking about an NGO where you're getting people from all over, not just all over a country, all over the world. So you have varying levels of education, experience, and practice. And then that within themselves, the team is shifting around. So just having somebody there that can, a leader that can kind of bring everybody together, at least talk through, hey, this is how we're going to handle triage. And whether that's, once a week or once a day or a couple times a day, hey, let's just walk through this quick and, have some quick lessons learned before the next batch comes through. I was wondering like you mentioned before, receiving 50 casualties, they're dribbling in, 4, 5, 8 at a time. You're doing your triage. Do you have communication with the front to find out how many casualties you're receiving, or are you just kind of receiving them? And how are you avoiding just just burning up your logistics, tubes and blood and all those things?
Right. So yes, we did have ways of communicating with the front. We had radios that we would communicate with. Okay. And that was very helpful. We always also had an operator or scribe would then be informed about incoming casualties, would already write down the vitals or pattern of injury or so that we would have an idea about the incoming injury pattern. And then so we were actually almost never overwhelmed with a big number of patients suddenly appearing at the treatment unit. So that was definitely helpful. To also kind of mentally be prepared for what to expect, because we had situations where Vic actually placed a surgical crike in the field because that patient had endured a devastating injury to the mandible after he was shot through the neck, and he was not able to breathe, so he had to establish a surgical airway. And so that was like one of the first casualties that was coming in on that day. And so, we were aware that we had a patient with a severe airway problem and possibly also a bleeding problem. So we were able to prepare for that, just minutes before that guy arrived, that's like so valuable time. Regarding the equipment, I kind of try to estimate the number of rough casualties before every battle started, just based on statistics of the International Committee of the Red Cross. They had written or authored a really good read, a good book for any surgeon who was considering going into the field and working in war-torn areas. And it's called War Surgery. And in there, they described, common injury patterns, common statistics on how many casualties to expect based on attacking soldier numbers and those kind of things. So we'd always try to kind of estimate the number of expected casualties and how many we would actually be dealing with. That's so what you also see is that, when you look at these statistics, most of the time, I would say, if you look back over history, the last 100 to 150 years, even though military tactics and technology has changed a lot in that time, you still see that when dealing with casualties, most of the time, let's say 60 to 70% of the time, you're dealing with injuries to the extremities. And then, there's a much smaller percentage of patients that sustain injury to the chest. So just based on that, maybe this simple example, of course, then you're going to be preparing for these extremity injuries so that you're able to, clamp vessels or maybe reconstruct arterial vessels if that's necessary, and that you have equipment ready to do like a fasciotomy or maybe even if you have to perform an amputation in the field, that you have these tools readily available. And then, of course, you're not going to have like 100 chest tubes or something like that. Because maybe, if you're dealing with many battles or conflict situations, you might need them in the end. But for one single event, you will not need like a ton of chest tubes. And even if you don't have chest tubes, you can still you can still save someone, by simply doing a finger thoracostomy. So this SAD, that way of thinking, that really helped in getting everything ready, having enough equipment. And also, we just noticed that, we were, of course, limited on package sizes and carrying canvas capacities and truck capacities. But in the end, everything all the equipment that we took with us was really important to have with us. Like we carefully planned beforehand, not just me, but communicating with Vic, but also with other members of our team, what would make sense to take with us. And that way we also really put together a sort of a trauma kit that really helped us and was sufficient.
That makes sense. So when it comes to gear that you pack, are you taking into account, distance from the front, distance to where you're evacuating your patients to, and try and build your gear to kind of bridge that gap? Or were you trying to build to a certain capability?
Yes, I think both questions I have to answer with yes. So we were built to be able to perform, the absolute rudimentary damage control surgery. So, I mean, not talking about thoracotomies and laparotomies, although I did have some instruments with me. I mean, to perform these procedures if that would have been absolutely necessary. But that was not, that was not the primary goal. The primary goal was to perform these stabilizing damage control surgeries. And for that purpose, I think you could say, yeah, for that purpose they were built. Also, when looking at equipment that I took with me, we only had like the most crucial instruments, the most crucial tools, medical products that we would need to stabilize someone. And this list is actually it's not very long, because it was my, or should I say, yeah, because it was my first time going into such a situation. I kind of I had to read in different types of literature about this topic, and also about what to pack, what to bring. Of course, you can like go crazy about the equipment that you take with you, right? I mean, you could take basically anything for just like, for just in case. But I think there is a trauma kit, or like, I'm not sure what to call it, like an austere environment kit, or forward surgical unit kit that really like covers the most important things. And actually now I'm talking to a Norwegian vascular surgeon who has been to Myanmar with FBR before me, who is also going to return in the future. And we're talking about, putting together a mobile surgical kit, that can be used in austere environments, just like in Myanmar. And it's a kit that can be transported very easily, even, if you only have some trucks available, not many shoulders, we can put these packs on. Just kind of covers the most important instruments and tools and, parts to save a life. Yeah, I mean, we were definitely focused on, so that we would be able to travel as light as possible, but still could perform these damage control surgeries.
Because obviously I'm not a surgeon, I've never been on a surgical team, but in a place like Myanmar or Ukraine, or essentially fill in the blank nowadays, the idea of mobility and speed of mobility is increasingly important. Like, just unlike GWAT, Afghanistan, Iraq, where we just threw an enormous amount of money at it and built our own infrastructure, which was incredibly successful, but not necessarily reproducible in modern conflicts, I guess. Mobility is what's going to keep your infrastructure intact, and your surgeons, which don't grow on trees, alive, so that they can continue to do their job. I guess, how important, when in your experience, how important was that mobility, and how, I guess, without giving anything away, like, how fast is fast, or how mobile is mobile to you?
Sorry, I didn't get the last half of your question. Could you repeat that?
So, yeah, sure. So again, without, giving away any kind of real secrets, but mobility, like, how fast could you break things down, travel, and then set things back up?
Uh, when you consider that you would, worked on the open on tarps, if it has to be, then I guess you could pack up in 30 minutes and move out and reposition, and then have everything ready again in, I mean, maybe 40 to 60 minutes. Yeah, because we were not traveling with any heavy equipment or anything that you would have to assemble and put together or something. And what was also very helpful is that all these people from Myanmar, they're so disciplined and so motivated and so willing to help you that they can just build a surgery table out of bamboo within 10 minutes, and then even create some sort of roof over you. And they're very, very creative and very fast in just building things out of bamboo or whatever the jungle has to offer.
Okay.
But what it really also takes a surgeon to be very flexible and creative as well to function in such an environment. Because if I would have been a surgeon who comes in and it's like used to be in a hospital OR and stuff like that, and if I couldn't have gone past that point, I was just accepting the environment that I was in, and just accepting the fact that I could not work sterile, and I would have to use a surgical instrument multiple times without being able to truly clean it down and re-sterilize it before using it on another patient, then it wouldn't have worked. And so, yeah.
So,
Yeah.
I mean, maybe if we can chat about that for just a second. I mean, coming from, a Western hospital, things are the way they are, right? Everything is sterile, it's clean, it's a controlled environment. Like all the variables are taken accounted for. Now you fly to the other side of the world. They're building tables out of bamboo, and you have tarps, and what kind of culture shock was that? And I guess, how did you prioritize as far as what you're willing to bend on and what you're not?
Sorry, last half of the question.
How did you decide, this, I can bend in this area? Okay, it's not air conditioned. I'm on my knees, not standing. There's no walls. It's just jungle, and I have a tarp over me for shelter. Versus, dirty equipment. How did you bend, or how did you make that decision about where you can be flexible and where you can't be?
Or who am I doing this for? And in all cases, it was the life of the person that was in front of me. And so I think that was the most important factor, what made it possible for me to just deal with every situation. And of course, there are certain things that you cannot bend, and that's how to deal with a transected artery, or how to how to deal with somebody who is almost bleeding to death. Of course, these things you cannot bend. You just have to become very creative in how to prevent that from happening, that somebody really bleeds out of just in front of you. So I would say these basic principles: advanced trauma life support principles, damage control surgery principles, just the surgical techniques that you utilize to save someone. Those things you cannot bend, but everything
absolutely
around that, yeah, I think that's. I mean, you just have to deal with the situation, with the environment that you're in, and just accept that in many cases and get over that and just focus on how do I save this patient's life, or how do I prevent this limb to become ischemic, and how do I perform damage control surgery so that somebody gets to keep his limb or gets to keep his life.
Right? You only have so many vehicles or so many people that can carry other people so far. How are you sorting through who gets to go and who doesn't?
To be honest, maybe that's surprising, but we actually were never confronted with a situation where we wouldn't have enough transport capability. We always worked very closely with the local, with the local resistance troops, and they had a constant flow of pickup trucks, and so actually many times they were waiting on us, the medical team, to be finished with the procedure, and would say, "Well, we're ready to take the station. You can load them up and off you go." So in that way, it worked very well, the system. But of course, I mean, that is all only possible if you communicate very well with the local forces, the local people on the ground there, and if you cooperate. I mean, we couldn't have done that without the resistance troops. I mean, we as FBR, we were having, I think, 5 or 6 pickup trucks with us, but often we would have to use these trucks for the transport from the frontline to the treatment area to this forward surgical unit. So they were constantly driving back and forth, and they were busy with bringing these critical patients in, and so they were not available for long evacuations to other hospitals. And so this very close communication with the local people, local forces, that was critical. But it worked very well.
So what other lessons learned did you pick up being in a very mobile surgical team in a very dynamic environment?
Sorry, the second half of the question you missed again.
Okay, that's all right. What kind of lessons did you learn being in a very mobile surgical team in a very dynamic environment? If somebody else was to go follow behind you, what advice would you give?
Of course, there are some lessons learned. What we already talked about. So regarding the importance of having a sterile surgical field and having all the instruments ready, having a clean and sterile set of instruments for every patient. Those are, in many cases, those were just, illusions that I had to throw out the window pretty quickly. And so I think the next time that I would go into such an environment, I would think more about, okay, how, do I have the tools ready to quickly wash down used instruments? Just how to get them as clean or as sterile as possible before using them on the next patient. So really this topic of in-field sterilization or in-field cleaning of medical instruments, especially in austere environments where you don't have electricity, you might or might not have electric power. That's a topic that I've been thinking a lot lately. On how to solve that issue. I think another lesson is also about what kind of personal, PPE, personal protection equipment you take with you. I certainly didn't think about the harsh environments that I would be working in before going in. So I would, for sure, even if it sounds strange, but I would like, for example, definitely pack knee pads, because that was something that I was absolutely just missing and would have made my life so much easier. Just thinking about these kind of things. Another lesson that I learned was how important it is to have a mobile ultrasound device with you. I didn't think I would use it that often, but it was so critical so many times, and just diagnosing a hemothorax or a liver rupture or free fluid somewhere, things like that. Very, very valuable to have with you. So really every time try to have that in your pack, so that you can just do that ultrasound diagnostics wherever you are. That was really critical. The whole transfusion system in the field when you're not near a hospital with a blood bank, that also turned out to be a very critical point. So what we actually did was almost everybody on our team was blood sites. So that is a very important thing, in my opinion, that you know about the blood types of the people on your team, and that you have all the equipment with you to be able to do in-field transfusions, because that's whole blood transfusions, and that was also a very critical thing that saved many lives in the field. And I always made sure that wherever I stayed, wherever I set up a treatment unit, that I would have at least 2 or 3 universal donors on my medical team, so that in case of the need for transfusion, we could tap their blood, transfuse it in the field. Yeah, that's also a very, very important lesson that we learned during our mission. Yeah, even I tacked a central venous line before I went into the mission, and I was like, when I packed that thing, I thought to myself, well, I'm never gonna need that in the field or in the jungle. It's like, it's such a hospital and intensive care unit thing to have these central lines. But in the end, on the very last day, hours before we left the country, we had one of the most severe cases, somebody going into hemorrhagic shock. He had almost bled out when he came to us, and put in that central line in his subclavian artery, and we were able to transfuse like 2 or 3 units of blood simultaneously and just resuscitate him aggressively and fast. And that, I think that's what saved him in the end. And so, even sometimes even taking these highly sophisticated tools, but in the right hands, they can totally save lives, even in the most austere environment. Something that we've been talking about with Free Burma Rangers, also thinking about future missions like this last one to the front lines. It is, I think, also absolutely critical to think beforehand about a standardized trauma kit that you go through with the whole team, that you really think about each item on that list, and you put together a kit that just covers the basic damage control, resuscitation, or surgical capacities. I think that's a very smart and important thing to do before going on a mission. These are the most important lessons for me. Of course, we can go into detail about which types of instruments and which kind of surgical tools or drills. I mean, this is a situation that I do want to talk about. But we had 2 cases with traumatic brain injury, and the thing is, in many of these armed conflicts, the soldiers, the fighters, they didn't wear any helmets, so they were very vulnerable and susceptible to traumatic brain injury. During one of those battles, we received 2 casualties, and obviously, one had a penetrating brain injury, and one had blunt traumatic brain injury, but they were both having, most likely, a hematoma. Yeah. Whether it was, subdural, epidural, of course, there's no way of finding out in the field, but they were clearly showing signs of increased cranial pressure, and And so, I mean, we didn't have any tools to deal with that. Nothing.
Yeah.
Because, I must also say I personally didn't expect to be confronted with the situation. And so for one patient, we couldn't do anything. And for the other one, we just, tried to evacuate that person as quickly as possible. And of course, if you dive into the books about war surgery or emergency surgery, damage control surgery, there's a lot of talk about, like performing emergency craniectomies or hemicraniectomies or, I mean, of course, you go very far if you would actually perform these procedures in the field without having immediate access to like an intensive care unit, or if you couldn't evacuate such a patient to a hospital within like 1 or 2 hours. But I think it's a very wise thing to think about the possibility that you might be confronted with someone with an intracranial hemorrhage where you might have to think about, drilling a burr hole or doing some invasive procedure or skull. Yeah. So, go for the future planning and also putting together these standardized mobile surgical units. I talked to my colleague, the vascular surgeon from Norway, to definitely also took a, for example, a multifunctional drill that could be used for burr holes or even a craniectomy. But, a drill that has exchangeable drill bits so that you would actually also be able to do a sternotomy or do an amputation. Yeah. So that was another important lesson.
Second.
Sorry.
But no, I just want to say thank you very much, Tom, for coming on and telling us about some of your experiences.
Yeah, of course. I mean, it was great. It was great to be on the show and to share some of these things with you. And I hope that this will help other medical professionals or also surgeons who are considering going into the field to be prepared. Yeah, I hope I can contribute in that way.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.